Hello.
Hello, good morning.
Good morning. Good afternoon. I was thinking, I think it may have taken us about 6 months to get this sorted, hasn't it? But we
Totally.
made it. We
Cheers.
made it. Yes, cheers, cheers. Thank you so much for joining me.
It's so fun.
Oh no, it's a pleasure to have you here. I see you are amazing at all of the posts that you put out. I mean, they're so informative and so spot on. I am in awe of how much content you manage to produce. I might get something out like once a week if I'm lucky. So well done. So if anybody isn't already following Kelly, your Instagram handle is well, it should be visible from this post, shouldn't it? But it's Kelly Casperson, MD.
MD, yeah.
Yeah. So we thought we would just get on and talk about all of the things that patients or ladies worry about in terms of risk and in terms of can they, can't they, that kind of thing. So should we start with vaginal estrogen?
It's a great place to start.
So in this country, and I'm assuming it's the same with you, it comes with a very scary leaflet on the inside. Do you have the same?
Yep. Yeah. We have what we call the FDA boxed warning, which they put on after the Women's Health Initiative on anything that contains estrogen, no matter the dose, no matter the location of the product. Yeah. So what that means, yeah, it says blood clot, heart disease, stroke, probable dementia. It's got these really strong warnings on a product that has not ever been shown to cause any of those things.
Yeah. And that's the problem, isn't it? Because whatever medication it is that you buy or you're prescribed, it's an instinct to read the information leaflet, isn't it? And then if there's something like that in the box, what do you do? And I suspect that a lot of these boxes just end up inside people's bathroom cabinets, never to be used.
Yeah, I mean, some people never read them, and then some people read them with a magnifying glass and then don't use the product, especially if the doctor doesn't ahead of time say, hey, if you are a person who reads labels, this is what it's going to say.
Yeah, yeah.
So a team that I'm part of, I couldn't be there, but a team that I'm part of met with the FDA in America last week to petition to take the boxed warning off of vaginal estrogen. So it's very exciting. The last petition to do that was like 2018, roughly, and it failed. The FDA said we don't have enough evidence. So last week was the next attempt to try to take that off of the boxed warning, and it's going to be a slow process, but they got the meeting.
So. Okay. Well, that's a step in the right direction, isn't it?
Yeah. And we do believe, otherwise we wouldn't be doing this, that we do have enough evidence to say it's safe. We're not just saying like, oh, you're scaring people. Like, we've got so much more data since 2018 saying how safe it is.
Yeah. And it's not only safe, is it? It's got advantages.
It decreases urinary tract infections by 50%. There's an interesting paper. Dr. Rachel Rubin did a paper, and she said if everybody in America on our national, basically, health insurance over the age of 65, if everybody with a vagina was just mailed a box of vaginal estrogen, it would save $1.2 billion a year in urinary tract infections alone. Wow. And then, if you take cost out of it, if you think about the number of hospital days and the number of deaths from older women from urinary tract infections. I mean, as a junior doctor, we used to see it all the time. Little old ladies coming in with urinary tract infections, and some of them don't make it out, do they? Yeah. I mean, the worst case scenario is these things kill you, especially if you're frail, and you don't have a lot of resiliency. And I think, what's an exciting part of the conversation is we're starting to say, like, is frailty, is it inevitable? Or are there things that we can do to not end up in the hospital with recurrent urinary tract infections when we're 82? Yeah. And for people who don't know, you can be on vaginal estrogen at any age. You can start your 91-year-old mother on vaginal estrogen. any age to be on vaginal estrogen. There's no window of opportunity for it.
And isn't it amazing the difference in quality of life when you do start, women who are much older on, because it's just like a revelation, isn't it? It's not, it doesn't even take that long to work for them to see the benefits, and they're just like, why did I not do this all those years ago?
It's noticeable, like just the burning, the irritation, getting up at night to pee, a lot of bladder things. And I think urologists are getting better and better, but I mean, I joke, I'm like, I give out vaginal estrogen 15 times a day. You can't make it through my clinic without me giving you vaginal estrogen because it's so good for the bladder.
Yeah. Yeah. So hopefully, so that we've had a few questions here. I don't know whether you can see them about kind of the circumstances that you can or can't use. We call it vaginal estrogen rather than vaginal estrogen. But so things like migraines with aura, or we've just said migraines, you can use
it. Not a problem.
Migraines with aura.
Use it. Not a problem.
Family history of breast cancer.
Not a problem.
And breast cancer is the one that everybody worries about, isn't it? So
yep.
I don't know how you do it in the United States, but we have if we have a patient who's had breast cancer, then we liaise with their breast cancer team. But really, it's a kind of courtesy. We do it out of courtesy more than anything else, because for most women, even if you've had breast cancer, using vaginal estrogen is safe, and also it can be beneficial.
Yeah, absolutely. I mean, I like to emphasize, like, all breast cancer is not created equal.
Yes.
Right. We call this disease one thing, and it's really like 25 different things. So it really, depends upon how are you currently getting treatment. Okay, we're going to be telling your oncologist a little bit more that we're going to do this. But I mean, women are suffering. Yeah. Most of these women aren't coming in wondering about preventative vaginal estrogen.
Right? Exactly. Yeah, and we said,
whereas the rest of us just want to start when we're 50, which I think that's a conversation at least healthy women in the US are having. Because is it enough to prevent, is it enough to treat disease once we have it? Or should we really be talking about prevention?
But in every other kind of aspect of medicine, we seem to be talking about prevention so much more, don't we? Like even if it's not medicine, even if it's just like appearance, you start using skin moisturizers when you're 15. It's like,
we floss our teeth. We do a lot twice a day. We do stuff to protect our teeth.
That is
so true. We don't think about brushing our teeth as prevention.
Yeah, whoever kind of branded the whole kind of teeth brushing thing was onto a massive winner, weren't they? Because it's no different, is it? It's absolutely no different. You look on, why are your teeth any different to anything else? It's just one part. And you think about the hours that we spend brushing our teeth in our lives.
At least in America, a standard is we go to the dentist twice a year just for cleaning and prevention.
Yeah.
Right? And it's like, why aren't we doing that with more things?
Yeah, we should be doing it with vaginas, shouldn't we?
Definitely
makes such sense. So tell me about the attitude in the States for starting HRT, continuing an HRT, stopping HRT, all of those kind of things.
Yeah. So we're talking systemic now.
Yes,
just
sorry,
for everybody who's listening, we're shifting gears. So vaginal estrogen is considered local or topical. I also call it pelvic, right? So it's not going in your body, it goes in the vagina, vulva. Then systemic hormones is either a patch, sometimes oral, creams, gels. That the whole point is to actually get into your bloodstream, to actually get into the organs in your body. So that's what we're talking about now. The tide's shifting. I mean, I think the UK, I think the UK is ahead of us.
Still.
And the data supports that in the amount of women on hormones, that the UK is higher. Okay. Except for we do a lot of compounding of hormones in this country for various reasons, and we can't count those numbers.
Right.
So if we count as far as who's on prescriptions. So I wonder if we're more equal if you count all the compounded stuff that's happening.
Interesting. And so at what point do you start women on HRT if they want to use HRT?
When they're symptomatic is that's kind of the textbook answer.
Yeah.
The textbook answer is kind of when you're symptomatic enough, which I do a lot of reels on of like, what's suffering enough mean, right?
Yeah. That is a
So
very good point.
so to me, it's really a conversation with the woman. But I think this is the natural progression of things, is as we become comfortable with the safety, as we become comfortable with the data on early use of hormones, there are some women who aren't symptomatic. Should they be excluded from this amazing, hormone because they're not symptomatic? Because if you look at brain data, bone data, heart data, all of it supports starting within 10 years of natural menopause.
Yeah.
But if you're not symptomatic, you don't get those good benefits. Like it doesn't make sense to me.
And what's the kind of public feeling about being, so say you are in that category, because in the UK it's shifted. So, over the last 5 years, you've got more women who want to be very, very proactive, and they're choosing to take, I mean, not all, but they're choosing to take HRT for the health benefits. But and we've seen a real shift in that. But what's the kind of, are people still scared? Are they still scared?
Yeah. And I mean, I always have to realize like the bubble I function in is not the bubble of the world, right? Because I'm like, doesn't everybody know yet? But a lot of people don't know. Their doctors got trained during the WHI scare. They don't know how to advocate. They're not in the healthcare system. They're not following us, right? So I still think there's a lot of boots on the ground education that has to happen.
Yeah.
But for the people who are educated, they want to take it as a preventative medication. Very common. Once you get the education, you want this.
Yeah. I think it is. Yeah, it's gonna take a while, isn't it? I mean, we still have, and I think you do too. We still have headlines, HRT, and the big one's breast cancer, isn't it? The worry about breast cancer risk, and if you show people the evidence about how safe HRT is, we then have the over medicalization argument. That's the kind of the comeback, which I find just awful, because is modern medicine over medicalizing everything? Or should we all
One might argue yes.
What's the point in having doctors?
I mean,
we're all going to die anyway, right?
Yeah, I mean, it's interesting because it's like in America, 25% of midlife women are on an antidepressant, and nobody's saying we're over medicalizing anybody with that. And I would argue 1 in 4, we're probably over medicalizing and the use of antidepressants. But it's amazing what we don't think we're over medicalizing, and then we're like, oh, we got 7% of people on hormone therapy, which there is no drug that decreases mortality. 0 drugs. Aspirin doesn't, statins don't, antidepressants don't, blood pressure medications don't. There is no medication that decreases mortality except for hormones.
Wow.
If I'm wrong, somebody please tell me.
I don't know that. I don't know those statistics, except that that if you are more likely to die if you are not using HRT. That's the statistic that we've always been taught. But it's still not a popular viewpoint. But
that's nuts.
A quarter. I don't think we've got those antidepressant rates here. But I'd be interested. I don't know what our current rate of using antidepressants is. But I certainly know about all those women who are on antidepressants when they could be on HRT.
Yeah, we're over medicalizing the wrong thing often.
Yes. No, that is gosh, that's frightening, isn't it? And so how are we going to turn this around, Kelly?
We do Instagram lives. This is what I think. At least speaking from the US. Our doctors are busy. They're strapped. They see 20 to 30 people a day. They are not going to go out, get the education, and turn the boat on this. They're already tapped out. How we're going to change this is have the women go into the doctor, have the conversation, advocate for themselves. This is really a grassroots healthcare of turning things around. Because the healthcare system, we can't wait for them to do it. We have data. We just need women going in saying, I listened to these people, I've read these papers, I want hormones for X, Y, and Z. I will follow up. Like, I truly think this is coming from the women.
It's a it's a good point. I mean, we've seen that quite a lot here. I suppose sometimes again they turn it on the head. I mean, so I wrote a book with a lady called Davina McCall, who's a TV presenter here. And some of my patients go to their doctors and say, "Oh, you know, I've read about HRT. I really want to try it. I've got this symptom, and I think it might be really useful for me." And there's a backlash against the fact that it is now in the kind of mass media, and there's something called the Davina effect, which is to blame. Those words, to blame for this big increase in demand for HRT. And people jumping on the bandwagon, and women have been through the menopause forever, and why is it now such an issue? So all of those things. So it's so hard. Like, I've watched the pendulum swing like backwards and forwards and backwards and forwards. And then we had, recently the Lancet series, which in my opinion, were another step back. It looked like things were being really quite progressive, and then bam, again, and our nice guidelines update, and it just feels like we are trying really hard to just present a balanced view of choice, letting women know that these are their options, and you make a little bit of headway, and then it's back again.
I mean, a lot of this is sexism and misogyny. I have to think it is, because we've got so much papers. We've got women saying, I want to try it, and they're being told no. I'm a urologist. When a man comes in and says he wants help with his erections and his low libido, we don't ask him if he's suffering enough.
Yeah.
And not until you hold up the genders and say, are we treating these genders equally in healthcare, do you realize the problem isn't the data. We've got the data. And another example, this might be more useful for the US people, but a while ago, like 20 years ago, there was a guy running for the president. His name was Bob Dole. Bob Dole did a commercial for Viagra. This is somebody publicly, erections, running for president. Nobody's telling them we're over medicalizing erectile dysfunction. Nobody's saying, they say the Bob Dole effect, but in a very positive way, because it educated men to a medication that could be useful, right? So I'm like, I've got knowledge of men going out advocating for men, and it works well. So we just have to keep doing it.
God, that's fascinating, isn't it? And yet, yeah, when Davina does it, or when Lisa Snowdon does it, and Halle Berry has talked about menopause recently, hasn't she?
Yeah.
And what kind of
Halle Berry, Naomi Watts, Oprah,
yes.
Oprah, Michelle Obama, like, people are speaking out, and it's wonderful.
And there's support behind them. It's not them jumping on a bandwagon, and it's generally supported, is it?
It's generally supported. But brilliant. I mean, our tolerance for women suffering is greater than our tolerance for men suffering. Yes. And until we believe women need to be believed. I believe you when you say that you can't sleep. I believe you when you say you don't feel like yourself. I believe you when you say that sex is painful.
Yeah.
Women need to be believed. And that's why it stings that I have to tell women, like, go get a second opinion, go get a third opinion, go pay private. Like, it's a burden, because healthcare hasn't caught up to believing women and using medications that are proven and safe and cheap.
Yeah, it's phenomenal, isn't it? What about testosterone?
We love testosterone. I want to know about testosterone in the UK.
So it's kind of exhausting, really. So testosterone Don't you
I'm
find?
sorry.
Not your question. The kind of attitudes towards things like testosterone. So I think so. At the moment, the guidance is in the UK that you can start a woman on testosterone once she has been re-estrogenized with estrogen, and proving that she has a distressingly low libido. So
Yeah. Are
we
you
have
suffering enough? Are you suffering enough to get a hormone that your body naturally makes but goes lower with age?
yeah. And so how one quantifies what how distressing, how is distressingly low different to just low? I don't know. But that's where we are at the moment in terms of guidance. You are not supposed to prescribe for things like mojo, feeling yourself, that missing piece that a lot of women describe, cognitive function, strength, those kinds of things.
Here's my big question. Sorry to interrupt. Libido is a mood. Fair?
Yeah, fair.
Mood is from the brain. Fair?
Fair.
So testosterone acts in the brain. Fair? Fair. Okay. So testosterone is a brain hormone. It helps with mood. Libido being one of them. But anybody who thinks that libido is this separate little exclusionary thing, it's a brain mood.
And that's the conversation that I normally have with patients, is that it's very, very unusual for somebody to just have a distressingly low libido in pure isolation. I've never seen that. I don't know whether because everything's all mixed up together, isn't it? I mean, if you're feeling fantastic, you're likely to have a libido that's great for you. If you're feeling terrible in every other sense, that your libido is likely to go hand in hand with that. So you can't. It's impossible to just kind of pick one. I think to pick one small factor in isolation. We have the added.
Yeah.
I don't know about you, but we have the added complication of we can't get the female product on our NHS, on our National Health Service. I don't know whether you can. It's different with you.
We have no female product. Do you guys have Androfem yet?
Yes.
Has Androfem?
But not on the
NHS. Right. But it exists in the country?
Yes. Do you not?
We don't have Androfem. We don't have anything that's appropriately dosed for women.
Oh, I didn't know that.
Cash or not cash.
Wow. So what do you?
So that's where you have to compound it, or you have to get a male product and microdose it. But yeah, Androfem's not here yet.
Oh, right. No, we've had that ever since I've been prescribing it. We've had Androfem.
What's cash for Androfem? If you just wanted to pay private for a tube, what's it cost?
It's It's about £100, and the tube lasts you about 3 months.
All right, 3 months. That's not bad.
We think here that's considered very expensive. Because we're used to having prescriptions on the NHS for £10 or £12 a pop. So we're not used to paying anything for healthcare at all.
Yeah.
But
that was interesting because you guys have what's it called, the tab, the vaginal estrogen tab that's over the counter now in the UK.
Gina or Gina. I don't know how you're supposed to pronounce it. Yeah.
Gina. Yeah. Because from the US standpoint, we're like, it's amazing. It's over the counter. It's amazing. And then all the UK people are like, it's so expensive. And it's just like, the perception of it, because we're like, it's still expensive with insurance here. So over the counter would be awesome, just because then you get to avoid a doctor's office.
Okay. Gosh, it's interesting, isn't it? But we still have criteria about whether you can get it over the counter. Yeah. So you have to be postmenopausal and over 50.
Yeah.
And it still comes with the leaflet, telling you that you're putting yourself at risk if you if you take it.
Yeah.
Yeah. But what's the criteria for you being able to get over the counter Gina or Gina in the US? Can anybody get it?
I don't think it's going to happen.
Oh, you can't get it? Oh, sorry. Oh, I thought you could.
No, we want it. That's why we're like, the UK is so lucky. And then the UK is like, it's expensive. And we're like, we pay money for it over the counter. There's no over the counter vaginal estrogen here.
Oh, sorry. I misunderstood you. So could you go to your GP and get some? Yeah.
Yeah. But you're still paying. Like the cheapest vaginal estrogen is the cream, and the cheapest you can get that's between $20 and $30 for a tube.
Right. Crazy stuff.
It's not bad. I say if it prevents one urinary tract infection, it's paid for itself.
I suppose it has. Yeah. Yeah. No, it has. Wow, Kelly. I mean, we've got so far to go, haven't we? Yeah, it's not very often that the UK kind of feels ahead in things, but I think we probably still are than the US in this.
Yeah, I mean, you've got over-the-counter vaginal estrogen. You have androfem, so it's appropriately dosed testosterone. You have pretty cheap medications when you do get them,
Yeah,
which is nice.
Yeah.
So yeah, we've got a ways to go.
I think our HRT rate amongst kind of eligible women is about 15%. So we're significantly.
We're getting this is what I mean, and the data is starting to show this. Looking at the women who never stopped hormones, right? We're going to start seeing health disparities, and we're going to start seeing more health disparities between the educated, privileged, and the people who don't have that. Because when you start on hormone therapy, you have a 50% decreased risk of heart disease, about a 30% decreased risk of dementia, if you want to believe Dr. Mosconi's meta-analysis, which I believe that one. We're probably saving marriages because of decreased pain with sex and sleeping and all that stuff. So it's not going to go without notice, the disparities in healthcare.
We're keeping these women in work as well, aren't we?
We're keeping these women in work. So to me, I'm like, this is no little thing to be like, consider hormones. This is a profound change to society potentially, because we're keeping women functioning. And this whole, I go back to, how do you want to age? When I talk to my women and I'm like, what do you want to be doing when you're 72? And actually get them to think 20 years down the road, they're able to make a very good decision then. Yeah. Especially if they're seeing their mother age well or not well, right?
Yeah.
Of like, if you want to be out and exercising and curious about the world and having relationships, like, you need to feel well. And there comes a point where your body just needs help. And why aren't we helping our bodies live well?
I think it's culture, isn't it? I mean, I totally respect there are some women that just don't want to use HRT, and for some it can be such a hassle, can't it? I mean, we see that cohort of women that no matter what you do, they have a side effect, or they get bleeding, or they but for the majority, I think it's fair to say, for the majority, it can be really really beneficial.
Yeah, totally. And to me, I'm like, you probably have this where you are as well, but in our culture here, women really want to be natural, whatever the hell that means, right? Like, I live in a house and I have a car. Like, we're just not natural at this point. But there's like this stigma of doing it naturally is very interesting in how that limits women from considering options because of what they think natural means. And I would say, living to 95 is not natural. Like, yes, we've lived a couple of years past menopause in the back times, but now we're living 30, 40 years past menopause, which isn't natural. Like, we're only living that long because we have antibiotics, and like, we're really good at trauma care, and we're decently good at like cardiac care.
I know it's so, yeah. I mean, I don't, I try and avoid kind of confrontation and argument with people on social media in particular, in life, but particularly on in social media. But when people argue with me about kind of what's natural and HRT is not natural and women have been doing this forever, and yeah, I mean the biggest thing is antibiotics, isn't it? You know, what proportion of women who are 45 today would not be alive if they hadn't had antibiotics? You know,
There's a paper on that.
Oh, is there?
Yeah, so I'm writing a book about, I'm writing a book, so, but there's a paper that says on average, the average life is extended 26 years because of the invention of antibiotics.
Amazing. Yeah. You know, you think about the number of times you have tonsillitis or a urinary tract infection, just those two things. Like, and then blood
Totally.
cancer.
And antibiotics, my friends, are not natural.
No.
I mean, you could argue if they kind of exist in nature, but like not how we've channeled them to fight infections.
Yeah.
Yeah.
And neither is obstetric care, neither is diabetic care, neither is, you know, arterial stents, neither are, you know, none of these things are.
Shoes.
Shoes, yes. Glasses.
Glasses. I know. So that's why I love the conversation so much, is because women come in with these fixed mindsets of like, I'm afraid, I want to be natural, blah, blah, blah. And then you're like, what do you want to be doing when you're 72? How are you going to keep yourself healthy? And you give them the data, and then they make good decisions. They just don't have the information, right? And so that's our job.
Yeah. Well, we'll keep on at it, Kelly. Yeah.
I wouldn't. I mean, it's such a wonderful topic. I love it. I couldn't see me doing anything else.
No, me neither. I think it's a privilege, isn't it? And yeah, the ability to kind of turn people's lives around, you know, without, you know, being in a very straightforward way with absolute minimal risk is just, it's, I think we have the best job. So yeah.
Yeah. Yeah, totally.
Kelly, thank you so much for joining me. I'm so glad we finally made it together, and
totally.
I hope we didn't get up too early. And
nope.
Yeah, we must definitely do it again. So thank you.
Very fun to chat with you. Thank you for the opportunity.
You too, and I'll see you soon.
Sounds good. Bye, everybody.
Bye. Bye.